hospitals to formally introduce the three speakers. Thank you.
Thank you so much, Dr. Srinidhi. I have the pleasure of introducing three stalwarts. You may have heard all of them. Miss Paula Wilson, she is the President and the Chief Executive Officer of the JCI and the JCR. Sorry, JCI and JCR, the Joint Commission Resources and the Joint Commission International. They are non-profit organizations working to improve the healthcare quality and patient safety in more than 100 countries across the world. They are the leading healthcare they are leading healthcare service providers or improvement. They set up quality consulting and educational services with online compliance tools. And Ms. Wilson has more than 35 years of experience in this healthcare industry. Prior to joining the JCR, Ms. Wilson was a faculty of the Columbia University School of International and Public Affairs. She was also in the Wagner School of Public Services in the New York University, where she taught courses on financial management and corporate compliance. Her healthcare experience includes very senior positions in long-term healthcare, health insurance, and public policy organizations. Thank you so much for joining us. The second speaker we have is Dr. Jacob Thomas. He's a medical doctor with a vast experience in hospital management, having served in various capacities in the Saime Darbe Medical Center. He also he's currently the chairman of the Ramsey Saime Dame Healthcare. And Dr. Thomas is also the president of the Association of the Private Hospitals of Malaysia and the Malaysian Productivity Corporation. So he works as a board member and council members of various organizations, and he is currently one of the board members of the JCI. Our third speaker is Mr. Horan Hendricks, who is the Chief Executive of Learning and Innovation in Qualtrum in Sweden. He has an academic background in psychology from the University of Lund. He's basically a child psychologist and holds a master's degree in business administration. He's basically a child and a school psychologist, and he's engaged. He's also a basketball coach, the national level coaching expert for that. He has 30 years of experience in the management of the Swedish healthcare system, and he's a member of the Jönköping country's top management and the strategic group. He's a member of the strategic committee for quality improvement of the International Quality Forum, which is organized by the BMJ, the British Medical Journal. I invite all three of these speakers to please give us their views. Thank you so much. We have three stalwarts with us, so may I request Ms. Wilson to come up and please give her.
Thank you so much. Thank you very much. Good morning. Namaste. So my name is Paula Wilson, and I'm going to talk to you for about 25 minutes, I think is what we are expecting, maybe a little more, a little less. And my topic's one that I think is very current and very vital to us as people interested in patient safety. And could we, there it comes. There we go. Okay, so I'm going to talk today about patient safety implications of technology changes that are happening in the healthcare arena today. I think it's an issue that's very timely, and so we'll be talking about that. But I wanted to just do a couple of minutes about JCI. I always begin with our mission. We are a not-for-profit. We're really committed to safety and quality. We do all kinds of work around that, but our key impact is that we do accredit hospitals and other healthcare organizations in different parts of the world. And this is the JCI footprint, or our global footprint map. And so we're headquartered in Chicago, Illinois, but we have offices now in Dubai, in Singapore, and we're opening an office right now in China, in Beijing. So we continue to grow and have a presence around the globe. This is our presence currently in India, and this is a country that we're very interested in growing our impact on safety and quality here. We have about 30 organizations that are either accredited or certified. Most of those are hospitals, and many of them are Apollo hospitals, and we're extremely proud of our relationship with Apollo, and being a knowledge partner at this conference is a key part of that. And I'm happy to be back in front of this audience, and I've done this conference before, and we always have people here because of the great content and the great work that Apollo does. So today I wanted to talk to you about all of the great things that come from technology, but with all good things, there are also risks and threats from a patient safety perspective. And so we'll talk a little bit about that. We've got some key best practices in terms of things that organizations need to be thinking about, and some of which you're probably doing. And then the Joint Commission International Standards, as you know, are published every 3 years. And so the 6th edition of our standards, and this is now 16 years of publishing standards, will be published on January 1st of 2017, and we will begin using those standards for surveys that begin after July 1st, 2017. And one of the changes in the 6th edition directly addresses the issue of technology and patient safety. So I love this photograph. I've used it in other places talking about technology a little bit. But it's a robot taking care of a patient. And in fact, robotics are quite common now in parts of healthcare. This might be a little extreme. I was talking about long-term care, and what are we going to do in order to take care of the aging population that's everywhere in the globe? In the United States, in Japan, I was just in Japan for ISQA. Literally every continent except for Africa has an aging population at the same time that we don't have enough providers of physicians, nurses, home care attendants. And one of the things that a lot of research is going on, and this photograph is from a Japanese firm, looking at ways can we augment human beings with robotics. So this is kind of a cute photograph, but it's a serious photograph in terms of that's probably our future at some point. And so one of the things we're interested in at JCI is what are all of these technologies, what do they mean in terms of patient safety? So today we're talking about health information technology. It's a broad term, HIT. And when I'm talking about that, it includes all kinds of things. It starts with your desktop applications, Word and Excel, but then it goes on to electronic health records, event notification systems, clinical decision support, very important systems, medical devices, which I'm going to spend a little time on today because they present both opportunity and risk, all of the machines that we use, imaging, implants, all of the M-Health, mobile health, that's growing extremely quickly. Consumers now expect us to be able to not just be face-to-face of interactions with them in terms of delivering care. They want to be able to access healthcare providers using their telephones and other types of technology, and we need to adapt to that quickly, but we also need to adapt to it from a safety and quality perspective. I wear kind of a unusual little band. This is a band from one of the companies in China that have, these wearables that counts my steps and tells me how I sleep. I don't sleep enough and I don't do enough steps. That's what it's told me over and over again. By the way, it has not changed my behavior, but I do have a really good record for a year and a half of not walking and sleeping enough. So, but the point of this is that this is becoming extremely common. And so this also introduces opportunity and risk in terms of you as healthcare providers. I was recently at ISCO, I mentioned, and a presenter there talked about ambulance drones. So everyone knows what a drone is and that they can get up over the traffic and they can take photographs, but they can actually deliver a defibrillator. And we watched a film of a drone going up and over the traffic of a major city and getting to a patient, and at speed that an ambulance could never do, while the patient's relative was on the telephone talking to the technician about how to open the defibrillator, how to administer it, and save a patient's life. And so in cities in India, we know that traffic is a huge issue. I think we're going to be seeing things like this. This is still relatively new and in the pilot stages, but has implications for us on a future basis. Dr. Watson is what IBM is doing with major cancer centers in the United States as well as around the globe right now. This is it's a supercomputer that has deep learning and artificial intelligence capabilities, and they're looking to use it to augment cancer physicians. As we have an aging population, we know we're never going to have enough physicians to take care of all the patients. So things like Dr. Watson can actually do a lot of the research. There's a very funny commercial about Dr. Watson explaining how the machine can read 80,000 words in like a minute or something like that, beyond any human being's capability. So these are things that are going to be part of our future, and I've talked about devices, and we'll talk a little bit about those as well. Whoops, wrong way. So I see it as a two-edged sword, the whole growth of health information technology. One of the areas that we know we could have some great outcomes is technology that helps us understand adverse events. So there are technological interventions that can reduce events, provide better responses to events, and provide us with better feedback, but the research is still relatively limited, but I think over time we're going to see a lot of improvement in that area. We know that things like smart pumps can really improve on dosing errors, but a lot of times they're not used properly. Human override, human interaction being one of the great challenges that undermine the usefulness of these kinds of machines. The same is true for auto dispensing kinds of machines. Actually, the experience, according to the research so far, is the barcoding is unquestionably been an improvement for us in terms of patient identification and reducing adverse events and errors in healthcare. But as I said, all of the opportunities are there, but they come with new threats. So one of the things I'm doing today also is that I'm going to give you some resources where these slides are going to be available. So if you're interested in getting better at understanding your threat and patient safety issues around technology, one place to look is the ECRI Institute, ECRI. This is a not-for-profit organization that's worked on patient safety issues for over 50 years. We know them well at the Joint Commission. We have no relationship with them, but as I was preparing for this talk today, they became an important resource for me. And so they have a lot of online materials that are helpful. And what they really do is research on whether or not all different types of drugs, devices, all kinds of healthcare is actually useful or not, and does it have an impact. But one of the things they did was this PSO deep dive health information technology. So they did a study of a large number of healthcare organizations, and they looked at specifically, they analyzed and categorized 211 HIT events. And so this is a summary of that finding. And basically what we're finding, and I'm going to talk about this a little more in terms of where do the common problems come up. So the most common problem is system interface issues. Next are wrong input. Then software system configurations. How does everything talk to each other? Wrong record retrieved and software issued functionality. So let's look at those in a little more detail. So on the system interface, this is the most common issue that happens in errors and issues related to HIT. And this is where the system's just not integrated. A physician puts in an order in the EHR, but it never makes it to the pharmacy. And so that creates an opportunity for error. The system software configuration. This is where someone tries to put something into the record and they're limited because the size of the field is limited, so they're not able to actually enter what they want to enter in terms of comment. Another one is software function, and an example of this would be there should be an alert when a pregnancy test is ordered for a male patient. There should be an automatic alert on something like that, and when that doesn't happen, that's a problem in terms of software function. So these are three of the top issues. And then we get into the issue of human and computer interface. These are a little out of order, sorry. So this is where we as humans working with the machine, we're creating problems. And so one of the most common problems here is when we put in the wrong data. One of the things, I work for a physician named Mark Chassin. He was one of the original authors on the IOM report. He's been a thought leader in patient safety for many years now, and he, you know, he's always a little skeptical. That's why he's a very smart guy. And so he reminds us all the time that the electronic health record has enormous potential and has made a big impact. But when the electronic record is wrong, it's wrong over and over again. When we made a mistake in a paper record, it stopped with that piece of paper. But now, because we have an auto-populate function on most of the electronic health records, if we put the wrong weight in, the wrong allergies, or the wrong ID number in, it populates all kinds of fields throughout the record, throughout the hospital record on this patient. So it's a bigger mistake than it would have been with one piece of paper. So this is where humans are using the machine, but they're not using it properly. Another is wrong record retrieval, and one of the things ECRI found in their study, and I saw this in a lot of the literature, is when you can open up two patient records at the same time. So you're standing in front of the computer, you've opened up the record for one, you've opened up the record for the other, and then you're interrupted. And I talked about nurse interruption yesterday. We estimate that nurses are interrupted every 6 minutes. Every 6 minutes. So one of the key patient safety issues is to have nurses not interrupted, because that's impacting lots and lots of things. But it also has to do with the nurse gets interrupted, goes back to what he or she was doing, goes back to the wrong record because two records are open and sometimes more. So we need to fix that so you can never have two records open. Right now that's very common, and it's created a lot of safety issues. Then in terms of other computer problems, the data does not get displayed properly. This is a big one. The system slows down or it goes down altogether. And so one of the things the standards are going to be asking is, do you have a plan? So we ask you for a plan when there's a fire. We ask you for a plan when there's a power outage. What's your plan for when the computer goes down? The software, you have to keep your software up to date. And that's a risk in terms of the computer itself. We use the equipment incorrectly, as I mentioned. And the thing that I think is most, I don't know, threatening maybe in some respects or a little scary is that we're a highly complex technical environment to begin with in healthcare. I mean, before we have electronic health records and wearables and devices and all of that, what we do on a day-to-day basis is extremely difficult and extremely complicated. And now we have a layer of heavily complicated technology to integrate with what is already a complicated system. So this is really hard work, is really, I think, the message here, and something that needs a lot of attention. The other issue on the human side I wanted to mention is the whole issue of copy and paste. So humans don't, when they have problems interacting with the machine, I mentioned those, but then these are serious issues as well, as when humans just ignore alerts and don't use the equipment properly and then cut and paste. And so another resource for you in terms of getting familiar with these issues is the Joint Commission website, and I've cited that later in the presentation. But this is from the Joint Commission, the parent company for JCI, where we do enormous amounts of research on patient safety and quality. And so copy and paste is a common function in use of electronic health records. We copy and paste all the time. When we're writing a Word document, when we're doing a presentation, cut, paste, cut, paste, cut, paste. I do it all the time. When I make a mistake, there's really no risk. I'm never near a patient. The worst thing that happens is I have a typo, and we can live through that. But when it happens inside of a health record, it's very, very dangerous. So cut and paste means that we're pasting outdated information over and over again. It gets very redundant in terms of the record itself, which means it's very difficult to understand what's the most important thing going on with the patient inside of the record, because cut and paste doesn't let you really see what the last entry was. It doesn't always tell you who did the entry, so it's very difficult to understand who the author was, when it was done, and then if we have bad information, it's repeated over and over again. Internally inconsistent progress notes and unnecessarily lengthy progress notes, because when you don't have to write it all out, you're just cutting and pasting. We don't pay attention to things like length and whether or not it's still hanging together and making sense. So all of these issues come from technology, and particularly around things like electronic health records. So if that's not scary enough, so we have all of those issues. And then these are headlines that I just cut and paste from recent newspapers about what's happening in the healthcare industry and ransomware. And so there have been some key cases. One of the articles I was looking at, since the beginning of 2016, 16 organizations have been held ransom in terms of their private information. I'm sorry, I got distracted there for a second. So all of these are headlines in terms of organizations that have been attacked. So one famous case in California, they were attacked, they paid the ransom, but what happens is an organization gets into your computer system. You get hacked, and we've been reading about hacking in all types of ways. It's very prominent in the US election right now. But when an organization is hacked, it's very dangerous for you in terms of its implications for you in many ways. So one of the things that's happening is, because of the increasing amounts of cybersecurity threats, the bad guys, the guys who are doing the hacking, they're looking for where they can have the best impact in terms of return on their investment. And they're looking at healthcare because we are notoriously not up to speed in terms of technology. We have been slow to the technological improvements that have been available to us. So in order to get the US hospitals to really actively use electronic health records, the US government has spent literally billions of dollars to create financial incentives for hospitals and private physician offices to actually adapt and begin using electronic health records. But the bad guys, the hackers, they know a few things about us. They know, first of all, that we need to have access to our data real time every day. We can't function if the system is down, which is why one of the standard changes is, what do you do if and when the system goes down? So we're prime targets because they know the data has to be accessible to us. It's literally a life and death situation. They know that we have money, so there's money in hospitals, you can hold them ransom, and that we have a weak infrastructure. We have not done enough in terms of employee training on cybersecurity, and we're vulnerable for attack. And we definitely have a high risk from phishing, P-H-I-S-H-I-N, phishing. Everyone heard of phishing? This is when bad guys try to get into your system. And one of the ways they do this, and one of the things you should try when you get back, if you haven't already, is a phishing expert will send an email to someone in your organization. And it looks very real. In fact, we had people phishing in the Joint Commission, sending an email from Mark Chassin, who's the boss of the whole company. He's the head of the whole enterprise. And it looked just like his email. And then so you get a note from the boss, you open that one up, and then there's usually some kind of attachment. And when you open the attachment, that's when the hacker attacks your system. So what we did, we've done a lot of training on this because we have to protect your information. Our customer information is private, confidential, and all of the reports that we do, all of that, it's not quite at the level.
I had the most amazing support system going through this. It's what saved me, literally what saved me. There are so many patients who are by themselves, and that's why it's so important to me to speak out, to advocate, to give back. And I'm very, very proud to have been a part of the the two laws for public reporting of hospital-acquired infection rates in the state of California. Our hospitals are scary places. Our healthcare system is broken, but there is hope. And that hope is patience, patient engagement, patient involvement. Albert Einstein says, you cannot fix a problem with the same mindset that created it. Patients bring a fresh perspective. We are the secret weapon, the magic bullet. Patience will change healthcare.
So, ladies and gentlemen, this is the organization. They sent me this video, lots and lots and lots of other stories. But wasn't it powerful? We realize what a patient has to go through when we don't do simple things, like what she said, washing our hands or making sure your equipment is sterile. So I think the patient safety movement is connecting people, ideas, technology to confront the large-scale problem of more than 3 million preventable deaths each year across the world. And we are part of that. We don't know how many happen in this part of the world. Even the US numbers, they say, is not properly counted. And so we want to be part of it. And I want to leave this message with you. Our mission is 0 preventable deaths by 2020. And this is the Patient Safety Movement Foundation. And these are new efforts in building or existing patient safety programs like what you're already doing through commitments to 0. And this is not something new. It's a fresh approach to an old problem. Convene, inspire, collaborate, and demonstrate leadership through commitments to action. Who can take action? Hospitals and hospital systems like the Apollo Group, healthcare technology companies, with lots of them around, GE, we have Philips, all of them have come forward and said, we will help you. And how do hospitals and how hospital systems commit to 0? By implementing actionable patient safety solutions. I'll give you the list, and it's not something you are not already doing. We also, this is some of the actionable patient safety solutions. And technology companies, how can they help? I'm going to rush through, but I'll leave all these slides for you to take and look at so that you can implement it in your organizations. Technology companies can look at providing data. You use their equipment, they can give you data on what happens through their equipment. And they can sign a pledge. We can also get patient advocates, people who look after patients, they are patients for patient safety. They can all make their pledges individually coming into this movement. And we find that we can make our model effective. Facilities shared learning across patient safety initiatives, sharing like this globally as well as at international conferences and even locally between your own hospital and network. The Patient Safety Council of Malaysia, it's small, tiny, but you've got such a huge organization and you can leapfrog these initiatives. What makes our commitment model effective? You evolve beyond avoidance of harm. You go beyond that. You find that you can commit by the year 2020, demonstrate effectiveness of protocols, highlighting tangible result and inspire others. We can demonstrate a changing healthcare marketplace to policymakers. Now, I go through very quickly. When they started in 2013 in the US, it was only meant for the US. But today, this year onwards, they have pushed it internationally. 51 hospitals and healthcare systems committed, 9 medical technology companies, and they found that they saved 63 lives a year. 2014, 100 hospitals and healthcare systems came in, 38 medical technology companies, and 603 patient lives were saved annually. 2015, 515 hospital and healthcare systems, 40 medical technology companies, and 6,571 patient lives saved a year. This year, they are thinking of 1,631 hospitals and healthcare systems, 45 medical technology companies, and they believe that 24,643 patient lives saved a year. And for next year, they anticipate 3,500 hospitals and healthcare systems, 100 medical technology companies, and 50,000 patient lives to be saved. And I think we all can be part of that. So this is the website. I want each of you to go in, and our hospitals here to go in, make a commitment, join the online community, and there is an annual conference as well, which if any of us can go, it will be good. It's new for me, but I believe that we have been talking so much, but we need to make a pledge and work towards it so that we can make our hospitals and our world a safer place. I want to thank this person, Tamara Minia, Tammy I call her. She's also a board member of the Joint Commission International. She is the patient safety officer of the University of Pittsburgh Medical Center, and she is one of the founder members of this Patient Safety Movement Foundation in the US. So I thank her for sending this information so timely for me to share it with all of you here today. And I encourage the leaders of the Apollo Group to take this initiative. All you have to do is just sign and be part of that whole effort. I thought you'll be the first in India, but when I looked up the website, there was one hospital, I don't recognize it, is in Karnataka, who've already signed. Then I thought maybe we'll be the first in Southeast Asia, and I looked in and I found that there's one hospital in Singapore, Singapore General Hospital, who already signed. So it doesn't matter, you have 50 hospitals in India with the Apollo Group, immediately make a commitment and be part of this movement, and I think we can together make a difference. Thank you, and thank you. Just want to leave a message. We have our own conference, the Association of Private Hospitals, 25th year next year. Last year, one of the two speakers were from here, Professor Anupam Sibal and Captain Usha Banerjee, and they created a big thunderous applause after their speeches. And I thank you all for being part of our organization. Thank you.
Thank you so much, Dr. Thomas. Very touching words on the clinic of the Edinburgh surgeon who had kept a leg with that statement below it, and a very touching video. It's glad to see that the organization which has the zero preventable deaths is now trying to achieve more than 24,000 lives saved a year. May I now request our third speaker, Mr. Horan Hendricks, please give his talk.
Hello everybody. Maybe I'm taking a big risk now, but I believe that patient safety is also a public health issue. So, can you please stand up for a minute and stretch your legs and talk to your neighbor? Just a minute, and don't leave the room, but talk a lot with your neighbor. Thank you very much. You see, I learned from my physiotherapist experts that sitting more than 20 minutes is like smoking a cigarette. And I believe in that strongly. And I have seen so many patient cases where smoking has hurt the possibilities to get a healthier life after a surgical operation. And I think that safety starts in the question of wellness and prevention work, actually. Maybe it's my background as a sports coach that brings those kind of questions to my mind, but I think it's so crucial. My name is Göran Henriks, and I have worked in healthcare since the early 1980s and been in a top management group since 1990. And I have the privilege to work in the most fantastic business. I think that healthcare, just as we heard in the beginning, is one of the biggest hopes, because we have values that we know drives us. Values like customer or patient orientation, everybody involved, team orientation, processes are the key thing, reduce variation, decisions based on facts, and so on. And I think that safety starts here. But it starts here only if we have a good school system. And I come from a country, Sweden, where I believe that the education level of our professionals are really the key for the good health and good care that we deliver. And there is no excuse if you not put a lot of efforts into how you take care of the young talents that come to our work. We need to have a very, very strong school system. Now, in my region, we have an academy that is named How to Change Healthcare. So today we have 20 PhD students just doing action research on our quality and safety work and publishing articles of how well it works. And I think that this is one of the steps we see in healthcare today, that all our journals are overwhelmed with articles. And I think that is a very good sign of hope, because we have to find new ways of getting all the knowledge together. Now, for me, this summer was a sensational thing, because my son, who is 26, came up to me and said, "Father, we have to play Pokemon together, Pokemon Go." And you know, the Pokemon Go made me realize that the world is totally global. In Sweden, we have 108 quality registers, and they are owned by the professionals, and they give us a chance to compare how well different areas in Sweden are doing. But the knowledge are too much into some of the professional groups instead of a system property, so we work a lot with this. But I realized when I started to play Pokemon Go that the computers that run Pokemon Go, they were understanding where I was in the world. So I went to a sports festival with a European game named handball, and it was 3,000 youngsters playing handball, and there were a lot of Pokemons that you could catch. Then 3 kilometers in another direction, I usually swim, and I'm very alone, and there were no Pokemons to catch. Maybe a single one or two. So someone has told the computers that runs this that they have to understand where people are. And this is the new level of artificial intelligence. So I feel that I am part of a global transformation, because this is the first time when every person that works in healthcare will have a chance to get feedback when they go home. Because if we use the same registers, we could get the same feedback wherever we work. And it's quite cheap also to build that as soon as we become members of the same system. So I think it's a very crucial time, where also, of course, then adult learning and our platform of competence among our employees becomes so crucial for our quality work. But I didn't plan to talk about this, but I thought that this makes it even more important with beautiful meetings like this. For me, quality improvement and safety started when I realized the truth in every system is perfectly designed for the results it gets. And I realized that not only when I worked in care, but also when I worked in professional sports and teams, that no matter how good my players was, if they couldn't play well together, the results didn't come. The second thing that I learned during the early 90s was that the critical resource is not the doings. It is to understand that you have to act before something happens. So then anticipation of things becomes very crucial. So you have the experience, but the experience are built of reflections that you do together to anticipate when there is a risk situation and be one step ahead. And then, of course, it is very important how we organize ourselves. And with this Pokemon development, we have to see that our houses and our service centers will not be the key for the mindset. Because we have completely different kind of segments, population groups, that approach us in completely different ways. Our science have developed a situation where many chronic cancer diseases are chronic. So if you have a prostata cancer or a breast cancer and it's detected early enough, you can have a very good life for many more years. People start to think that they are healthy, but they have got this disease for a moment. And the medication are so fantastic, and our detection resources of the problem are so fantastic, that it's true that if they get the right competence early in the process, the chance to live a healthy life even after this very, very serious problem is big. So then the house where it's treated is not important. It is the value center that can have the same resources in place of diagnostic thinking and technology then it's a different kind of house. Then we have knee replacement, hip replacement. Today, if everything works very well in my hospitals, people stay 1.5 days after a replacement. But that takes, of course, an extremely standardized approach. And the engineering and the flow logistics and so on are so crucial. And that's a completely different value logic from the value center idea. That's a different business. Now the third thing we are in is that many people needs networks to get along with their lives after they have started to be fragile in one or the other way. For example, my 93-year-old mother, Brita, she is still driving a car and she is still taking care of a house of 3 levels. But this can only be done as long as she has her network of 6 other women where she is the next youngest. There is 2 over 100. They call each other every day. They come from completely different social contexts. They have lived completely different lives, with some with terrible family situation, some in luxury. But you know, when you get that old, everything comes together to one thing: to keep your authority and autonomy. And when you keep your authority and autonomy, you suddenly feel the life engine going on. So they call each other and ask every day, "Are you there?" And they meet twice a week to make carpets, to make handkerchiefs and so on. And the automation of this hand-driven machines getting better and better, so their muscles can do it even if it's not that handmade any longer. But they are very proud to show and give us the handkerchiefs to Christmas. Now, that's a different kind of healthcare, where we in the municipality, in cooperation with the municipality, must develop safety thinking of prevention and risk assessments, so people do not fall, so people continue to eat, so people take their medication. If we don't get that value stream in place of networking, it will cost us a lot of money. Sweden and most of Europe are in a tremendous challenge because the amount of people that work compared to the amount of people that get over 65 is proportionally in the wrong direction. So more and more people have to live on fewer workers' incomes, because we haven't saved the pension funds, so the younger ones have to put in money that can be paid to the tax, so that can be paid to the elderly. So we need to have people going longer and longer. And it comes down to these safety issues: mouth health, nutrition, ulcers, mental health. And those things we can also put into a Pokemon Go artificial intelligent computer, and start to understand that if you're over 65 and fragile, to 66%, at least in Sweden, it's a big risk that you fall and get a hip fracture. And we know the effect of that. Okay. I started to understand healthcare and patient safety issues 1990 when I became a secretary in a very prominent group. It was a professor of surgery, professor of infection medicine, a professor of medicine, and the head nurse of a hospital. The CEO of the system told me, you should bring them together 5 times a year. That's what I hope. It became 3 to 4 times because they had such tension in their work and they had no place for discussing patient-centeredness and quality. We had also a national wave that said that everybody in Sweden at the hospitals should understand patient-centeredness. So I, young secretary, had to go out to all the wards and tell them to put on a kind of medal that says, I have patient in the center. And all the nurses and doctors were laughing and arguing that I was totally crazy because this they had had since 1900. That's why they are there. I felt not that strong after I had visited all these wards, and I came to this group and said, I'm not sure they like this campaign. What should we talk about in our group? Well, we didn't know what we should talk about for a year, but then suddenly the professor in surgery came and said, I suspect that one of our 3 hospitals are not doing good enough in colon cancer. It became very quiet in the room. How should we take care of that problem? We said, let's wait to the next meeting 3 months later, and maybe we know then what we should do. We met again, and no one knew what to do. So another meeting went, and 3 months later, we met again, and then the professor in surgery came to me and said, Göran, I know a guy who is a young talent surgeon in Lund, and maybe he can help us. So we invited him, and he came, and we asked him, what do you suggest? Well, I have read from NHS that they are using a method where they look for different indicators in the patient records that could explain if you get more days at the hospital. Now we are back to 1992. He suggested that he could read 3 hospitals' colon cancer operations 2 years back with a special trigger approach. We said, oh, that sounds very good, so let's do that. Now, the problem was that that took another 9 months for him to do that work. After a year, he came back and said, you are right, one of the hospitals is not performing well enough. It became just as quiet as it is here in the room now. What should we do with this knowledge? Because we couldn't make it transparent, because we had to think about our colleagues. So we decided that we should get all the surgeons, but only the surgeons with that are doing colorectal cancer operations, to a conference center, very beautiful, not as beautiful as this, but on the countryside with a lake, and we should start the meeting the Friday so we could continue over the weekend if necessary. They came up with the idea that they should travel to each other's hospitals and try to see if they could detect in their work patterns differences that could explain the result. So A went to B and B to C and C to A. So they did what we today call a triangle audit or evaluation of the situation. But that was the first time we started to talk about the secret of getting better quality is actually to look into the work processes. So how you work with the work is the key thing. The young physician, surgeon, told me, let them do this, and then after another half a year, let's see what has happened. The problem now was that after a year that they had traveled to each other, no one talked about this problem any longer. 2009, I became the chairman of 8 hospitals' cancer work, and we at that time had quality registers that were digitalized. It was 20 years after the first situation. And do you know, when we looked into the data, the same hospital were performing less good. I got first very angry. I couldn't sleep. But then I started to realize that tomorrow's healthcare cannot be distributed like that. So this is another aspect of tomorrow. We need to have focus, so the centers that can do the best has to do the best many times. So, because we have to protect the value of the performance and drive out the variation. Thank you very much.
Thank you very much, Mr. Horan Hendricks. Thank you very much for that very spontaneous and insightful lecture on the patient safety concepts. You gave a lot of real-life examples. We loved hearing about your mother, and we wish her many more years of good health. Thank you, and you also made us miss Pokemon Go because I don't think it's available in India. I don't think we have time for questions in this session. We've run out of time. Would you like?
Thank you so much, Ms. Wilson, and thank you so much, Dr. Thomas. It's been a pleasure listening to some of the very insightful talks and incidences. We would have liked to have a question and answer session, but I think we will keep it at our break time when they could interact with you personally. Thank you so much.
I would like to thank the chairpersons and the speakers for a very absorbing session. I request our Vice Chairperson, Dr. Preeta Reddy, to hand over the mementos to the speakers. Ms. Paula Wilson. Dr. Jacob Thomas. and Mr. Horan Hendricks. Now I request Dr. Rupali Basu, President and CEO, Eastern Region, to hand over the mementos to
light of humor. But I guess, we would now like the other colleague, of course, as I said, for the people who have come in late, one, Dr. Rao, of course, is the Chief Medical Officer for Indigo, which has been just 10 years young and has really taken, India by storm and are the leaders in the space. They have done this out of standard procedures. That's something that he's been talking about it a lot. Their culture is something that we know of. And I think now the next person I would like is the other 100-year-old iconic brand, which many of us, aspire to be at some point in time, I guess, as companies or whatever that is, it's the Taj. And I think Mr. Prabhat Verma, he's been there for as long as the brand itself, probably for 25 years now. And I think he can talk about how Taj, differentiates itself from some of the others who've come here, how they are patient-centered, the speed and turnaround times, a lot that he has, guest-centered, sorry, not patient-centered. I guess over to you, Mr. Verma.
Thank you, Krishnan. Very, very good morning, good afternoon to all our friends here. Doctors are very important. You take care of making sure that all of us are healthy. Preeta Reddy, Managing Director of Polo Hospital, my dear friend, Professor Dr. Sibyl, Prakash, and Dr. Rao. It's an honor to be here and with people who make life interesting, livable, and make sure that all of us are here standing and talking to you. So thank you very much for the contributions that you've done. As what has been told, and the subject is safety, concerns, security, hygiene. I think, hospitality industry, we sell happiness. You make people happy with their health, and we create a world where we say, come to us when you are at any hotels, and especially at the Taj. You leave all your worries to us. When you walk in a Taj hotel, you're taking it for granted that I'm at a place which has all of the measures that we talked about, safety, security, and hygiene is taken care. We don't go out and explain, as the industry practice could be vital in hospitals and in airlines. We don't have to show off that how much we care for you. But we have a lot that goes in the background. And in hospitality sector, when it looks all that glitter and glitz that you see from outside, there's a little bit of sweat also that happens. And that's what makes it interesting, because our job when we come onto the stage, and we call it as a stage, we are actors. Our job is to make you happy. And in doing so, what you call as infection, errors, and accidents, we obviously use them in a different connotation. The safety measures, the security measures, and the hygiene levels is what we correlate with. Obviously, there are instances which are not so nice to remember, but 2611 at our flagship hotel in Taj Mahal, Mumbai. Security, safety. Things can go, as our colleague, friend from Indigo, Dr. Rao was mentioning. It's not just the question of the brand image, it's the question of people's life. And both the airline industry and the hospitals do take care of that to the T. Our job is to obviously give you a blanket of cover of something which makes you feel more happier, and do that in a manner that we don't show what we are doing behind. But there's enough and more measures that we take. And when we talk about safety at the Taj, we talk about three basic criteria that we look at. One, that we will look up in the aspect of what do we do when we talk about safety. And it could be the health, life, we are talking about our own colleagues when we work in that environment. Are we making it completely safe in terms of their own well-being? Once we have that, when you make a hotel, all of that practices go into, which then gets depicted to our safety of our guests. Second part comes in is the security. And in today's world that we are living in, security becomes obsessive. And you've seen how the airline industry has taken it to a level where most of us as Indians, we get disciplined only at the airports maybe these days. The rest of the places we are not. You know, we walk into hospitals irate and very demanding. We come to hotels and we take it for granted that this is mine. But when I love the part when we go to the airports and when we board a flight. I think the best behaved Indians which we see is at the airline counter at the time that we are boarding. We follow everything to the T. So I think that's what we try giving it to our colleagues when we talk about safety inside the hotel. When we talk about security, in the days that we are looking at what happens and we don't know who's behind whom, there's very difficult part in a hotel industry that comes in. We don't want to frisk you. We don't want to open your luggage. We don't want to understand who else is coming to meet you. But these are all important. Government laws, regulation today demand that anything that happens, I don't want to scare you that next time you don't come to the hotel, but we do that. We ought to know. We ought to know what's inside your bag. We ought to know if there's anything dangerous. I mean, we're not very worried about what else are you carrying inside. It's your world. And that's why we say you come to a place where we make you happy. But the world of today demands that part of security checks where you have to be looked around to see, are we making sure that everything is safe? Then it talks about the hygiene. Hygiene is very important. I think when we talk about the checklists and the others which Dr. Rao was mentioning, there's a lot that we follow from the airline industry. But when it comes to hygiene, there's a lot that we learn from the hospitals. You know, we obviously give you a fancy meal, all decked up and dressed and presented in our restaurants and our banquets. But there's a lot of history, there's a lot of science that also goes behind. The HACCP regulations, the FICCI requirement, all of that has to be followed. But the most interesting part of hotels is that we don't want to put it on your face. We don't want to tell you that it has been tested by 3 people before you eat your dish. You'll never come to our hotels then. But this is important. This has to be done. And that's the only way that this entire fraternity of humankind can move forward. So I was talking more from the aspect of safety, security and hygiene. I don't want to bug you with how exactly what we do because we tend to learn a lot from the airline industry and the hospitals. But what is important for me to use this platform and talk to you is what is the philosophy which makes sure that all our colleagues are following all these 3 criteria which I just enumerated. For us, the safety, security and hygiene is what I initially said is about the errors and the infections and the fatalities and accidents that may happen in hospitals. But I was very intrigued to get this particular invite to say, what do I speak to fellow doctors here? You know, hotels and hospitals, you know, the word hospitality is kind of synonymous. You know, Atiti Deva Bhava, we say, you know, guest is God. And I'm sure when your clientele, the guest or the patients or however you want to call them, it's the most important part of your business as well. And the trepidations that people have when we compare the 2 industries, today you realize that there's so much of commonality that we have between hotels and hospitals. I think the hospitals are looking like hotels today. And that's the movement that has happened where more or less you realize that the swanky hospitals, as we call them now, are 5-star. Sometimes they announce themselves 7-star hospitals. You know, the kind of environment that you need to create is similar to what traditionally innkeepers like us were doing. Then there is also the commonality that we have in terms of the workforce. The hierarchical kind of workforce that is there in the armed forces, in your hospitals, from surgeons to doctors to janitors to housekeepers to, you know, food servers. It's a very similar kind that you have in hotels, that you have highly skilled people to semi-skilled people to unskilled set of people as colleagues of ours. What else are the similarity that we have with hotels and hospitals? I think all of you today also are very, very clear that if your patient goes happy, you will have more of them coming. I don't want to mean it in that manner, but it is, everybody is now rating, evaluating not only how good your medical practices are, because for us today, like we say in hotel industry, if I have a good room, if I have a good lobby, if I have a great restaurant, many of our guests will say, that's hygiene. Excuse me, that's what you ought to be. So if you say that I have a great hospital and I have a great set of doctors and my medical facilities is at that level, sorry, that's the hygiene. That's what you should be. So how do you differentiate then? It comes to the bare bones of making your patients happy. And in an Indian environment, or more so in an Asian environment, it is just not that particular, I still call it guest, but patient of yours, but it is entire fraternity around that patient. You know, the father, the mother, the mama, the chachas, the aunt and the aunties and the whole office and the colleagues. You know, it's like seeing off somebody at the airport. You'll have 400 people trying to say goodbye to one person. So that is the kind of pressure I'm sure you have to, you know, go through every day. That there is that particular person who's got his own network of colleagues around who's also demanding a similar kind of response. So that's the third part of evaluation as a guest satisfaction, we call it. I'm sure you call it patient satisfaction, but that is most critical. The fourth part that is much more common now is the way the digital world is taking shape. You know, for us in our hospitality sector, it's very disruptive. You know, you have companies which doesn't have no asset, no physical hotel, but their market cap is bigger than the best of the Starwood, Marriott together. And I think that's what is going to be the next wave, or it's already happened. The Airbnb you hear about, the OU rooms that you hear about, you talk about, you know, the middle channel that is taken away, the direct consumer touch that we had with hotel brands. That's also not there anymore. So I guess the digital front where people are now much more informed as a guest as well as a patient. And I'm sure most of the doctors will get mighty disturbed when the patient comes in to say, I know what the treatment should be. You are not asking that question. Similarly, we face those problems in hotels. Don't tell me how this dish is being made. My mother makes it better. So these are kind of, you know, you will have information there, may not be education. So your patient may not be educated, but he's well informed or she's well informed. So is the case with the hotel industry. Our guests today are highly informed. Today, having an airline on your doorstep, and thanks to our colleagues, everybody can fly. You have captions of airline company now saying everybody can fly. And I'm sure like you have in hotel industry, from a motel right up to a luxury 5-star hotels, the Apollo Hospital is at that level where it is to be at the pinnacle to say, I'm at the best level. So we face these kind of a typical kind of commonality between the hotels and the hospitality. But at the end of the day, we are still saying we are very spiritual. When I say hotels are very spiritual because we are making you happy, don't worry, I still charge you. It's not for free. Similarly, as in hospitals too, you make them hale and hearty. And it's not free, you have to charge them, but it has to be with a value proposition. So at the level that you ought to be, or at the level that we ought to be, it all boils down to those value propositions. At each part of this value creation, are you doing your best? So I'm going to talk about a second part beyond the commonality. There's something which is still common, but in a way that we see it, and maybe as an interest of the hospitals will be an important aspect. We talk about the whole life cycle of how a guest checks in and checks out. We call it the key hoteliering processes. I'm sure those terminologies are similar. You know, we call it pre-registration, you may call it what, pre-admission. We call in check-in. You sure can call it check-in as well. We call in-house facility and in-house experience of your patient. We call it error-free checkout with no billing issues. You also call how you say goodbye to a patient. We also say how do you engage with your customers who have gone. I'm sure you also have something to say post-stay or post-recuperation. So these are common processes that happen, but at the loggerhead. You know, when we say pre-registration, we are exciting our guests to say, come have a good time. Give me your details. And we will make sure we'll look after you without any kind of, transactional difficulties when you come in. I think that's a different connotation of reality in hospitals. The pre-registration can be painful. You have issues related to your health checks, your pathological report, you stand in a queue, don't have your water in the morning, don't eat breakfast, come for registration. It can be painful, and quite a few of us experience that bit. Then we talk about the check-in itself. At the time of check-in, we obviously say, welcome back, good to see you, we were expecting you. I don't think you can say that in hospital, we were expecting you. So this is an area that it comes in as part of the divergence. But the fact is that the time of check-in again can be very painful in hospitals. And I'm using these two examples of how a wow factor can come in at a time of check-in in a hotel and how it takes you completely in the other way when you are in hospital. Because everything is scrutinized, your billing, your papers, and you have to wait for that many things. Then you get into your room or your ward or whatever that's related to your industry. Then we talk about during the in-house stay, we get the possibility of understanding what is going right or wrong, and we can bounce back. The whole entire system of hotels works with that aspect of understanding how is the guest feeling during his stay. His food, his room, his towels, his cosmetics and the toiletries, his uses of the spa. At so many touch points, you will be able to take a feedback. I don't think that is to that extent possible in hospitals. And whenever I'm saying not to that extent possible, I'm trying to let your fraternity know that these are opportunities for you to connect and create that kind of well-being. So while a patient or a guest of ours is in-house, how do we look after that person, whether it is, we call it in-room entertainment, the spa treatment, the food and the menu and the beverages. You also have a limited, but nowadays a growing requirement of food, of the quality of food, of the ambience of the room, of what is there as comfort level in your own particular room in the hospital. So these are other things which works together or can be divergent. Again, at the time of checkout, in a particular life history of a guest in a hotel, it's a fond farewell for us. And we do say, please come back to us. Please, obviously you don't want to say that, please come back to us. But that part itself of a fond farewell is a very high moment, and it creates a lot of wow factor for our guests. There is a huge opportunity in hospital for that fond farewell. We know through our experiences that it can be very painful when you check out of a hospital. The bills, the medicines, connecting to who will be the follow-up points. These are concerns that comes by, but the process of checking in and checking out is the same. We do go back to our guests to say, when are you coming back again? How was your stay? I'm sure the hospital industry has reached a level where you are now going back to your patients to say, have you recovered? How are you keeping? Do you want to come and have a word with us, with our colleague or the doctor who has seen you? So this is this important fact that will be helping all of you and all of us together to ensure that when a guest walks in or a patient walks in, how do you insulate that person? The person goes hale and hearty and is willing to become your brand ambassador and talk about that, wow, what great services was rendered at this particular hospital. We are now also in a mode to realize how does this happen. It is a lot that goes with processes, and I completely agree with Dr. Rao, and I completely agree with all your fraternity people that there's so much of check-in and checklist that you have to follow. But in our world of hospitality, human capital, that is we are the set of people who make or mar an experience in a hotel. It is all to do about people. And we as hotel practitioners, we talk only of that front, that you have to look after your people for them to look after your guests. So there is a lot that the Taj is doing and is wanting to do to ensure that this journey moves in that direction. We have earmarked ourselves in a very unique approach, and I'm sure in days to follow, you will get to hear this. We are talking about who we are. Who should we be? So it's the question of being reputable. It's the question of being a company, as Krishnan was mentioning, for more than 100 years legacy of J.R.D. Tata, Jamshedji Tata, our founder. But it's all on the belief of giving back, and also in the belief of raising the self-esteem, and also being reputable and inspired by the nobility of Indian heritage. So all of that you will see of the Taj would be in a direction of that kind. We're also talking about our core Tata values. I don't want to read it out, you can see it. These are fundamentals to any business, and these are not patented that it has to be a Tata or a Taj value. These are values that needs to move around in every way, in all fields. We talk about a word called Tajness, and it's very nice to hear this word Tajness because it comes as a very strong emotional bond. And the bond that we have is the faith that you have in us, and we can't take it for granted. So, you know, the cornerstone for our entire philosophy of Tajness is the sincere care. And I hear and I read care is very important in Apollo hospitals too. So the pillars that we work on are those we sincerely care, which needs to be demonstrated for our guests, for our colleagues, and for the stakeholders that we live for. So, you know, there is enough and more that needs to be done, primarily on being very simple. It need not be some rocket science, but these words has to be demonstrated, meant, understood, and then and worked around. Tajness is all about, you know, sensorial, it's all about rituals, it's all about evoking a sense of place where we are. And in our attempt would be to move you, every time that you come to a hotel, it would be an experience. And that is the uniqueness that differentiates with the word Tajness. And then I just want to conclude stating that hospitals, airlines, hotels have one thing very common is our service. And whether you look after the health of a guest, whether you look after the wellness of a guest in a hotel, or the surroundings, or the safety of a person flying from one city to the other, it has to be done with sincere care. And that sincere care comes from the Taj group of hotel as the value proposition of Tajness. And I'll finish this particular discussion with you, or my chat with you, with a small 3 minutes video of Tajness. Thank you very much.
True luxury is in its details. It's built with time and care and an unparalleled vision. With years spent perfecting a craft, with decades spent acquiring a reputation, and with centuries spent building a culture. Luxury becomes real when it has a legacy, and the Taj is built on legacy. One that manifests itself in a feeling. One that has existed for over 100 years. A feeling enriched through care, warmth, and a strong sense of nobility. A A feeling seeped in tradition, etiquette and expertise. A feeling called Tajness. There's Tajness in everything we do. You'll see it in our welcomes and our farewells. You'll see it in our service and our sincere care. You'll see it in our customs and our rituals. You'll see it in our sense of place. Tajness is when you enjoy a cup of tea even more for the way it's poured. It's when you enjoy a cuisine not just for the way it tastes, but for the traditions it follows. It's when the days are beautiful, but you just can't wait for the sun to set. It's when you remember how a song made you feel long after you've forgotten its tune. It's when you find yourself heavy at ease even before the day has begun. You'll feel it whether you're here for leisure or for business. You'll feel it in our luxury suites, our palace stays, our beach villas and our jungle lodges. It's what stays with you long after you've checked out of our rooms. Tajness. You can feel it with your eyes closed.
Hello. What a session, ladies and gentlemen. Can we hear it once more for our two lovely speakers on the dais? Thank you, Colonel Rao, for what I can call giving us flight for thought. And thank you, Prabhat. I think I'll not be wrong in saying giving us food for thought. You know, it's such a different perspective to get from someone who's 10 years old and from someone who's 100 years old. But the essential message is still the same, that none of us will be here if the people that we look after are not safe and secure. And across processes, across lists, checklists, training, development, recruitment, ensuring that from the man or the darwan at the porch, or the person who takes your booking for Indigo on the telephone or the reservation assistant, right up to the very evolved person in whom you put your lives in, the pilot. The mantra is still the same, that it is the customer, it is the guest, it is the patient who needs to feel safe and secure, irrespective of what happens. But irrespective of what happens, it's actually a lot of hard work, there's a lot of thought, there's a lot of process, and obviously great leadership and organizational skills that conveys that commitment. For a lot of us in healthcare, I think there's a lot that we do, and obviously there's a lot that we can learn. Definitely from Taj example, you'll possibly know that what you see in the front of the house is as important as what is there in the back of the house. And there cannot be a disconnect between the two. As far as Indigo is concerned, I think the rigor of training and constrained training, even though you may be an expert, and constant reminding of the fact these are the tenets on which there is no negotiation, is what drives the fact that probably you will never ever have to go through a temporary incident once again. With those words, ladies and gentlemen, Thanks a lot. I think it's been a wonderful, wonderful 1 hour exposition of some new vistas that all of us in the healthcare industry need to see. In the paucity of time, there'll be no question answers. I know a lot of you have questions and answers that need to be asked, but these are gentlemen who are in the modern world, who are accessible on all platforms, whether it's email, you can write into them, they're on Facebook, they're on Twitter, and possibly Prabhat will say, walk into his hotel, he will buy you a drink, or Colonel Rao will say, come, let's sit on the flight and we can discuss. So with those words, off to the next session. Thanks a lot.
I would like to thank the speakers and the chairpersons for a wonderful session. I'm sure we had a lot to learn from these two industries, which we can imbibe and inculcate in the health industry. I request Mr. Jaideep Gupta, CEO Apollo Hospitals, Indraprastha, to hand over mementos to Mr. Prabhat Verma and Dr. Nageshwar Rao. I request Lieutenant General Dr. Naresh Kumar Parma, CEO Apollo Hospitals, to hand over the mementos to Mr. Krishnan Akileshwaran and Mr. N. Prakash. Thank you, sir. We move on to the next session, a debate on patient safety versus patient satisfaction. We've got a very dynamic chairperson, Dr. Anupam Sibal, Senior Consultant, Pediatric Gastroenterologist and Group Medical Director, Apollo Hospitals, who will anchor the session. The participants in this session are Professor Jonathan Gray, Director, APAC, New Zealand, Dr. Suresh Ramasubban, Consultant, Apollo Gleneagles Hospital, Kolkata, Dr. Sanjeev Singh, Senior Medical Administrator, Amrita Institute, Kochi, and Dr. Chan Bu Keng, Group President, Thomson Medical Center, Malaysia. Over to Dr. Anupam.
Good afternoon. Well, so at least I know everyone's awake. Did we have fun yesterday? Come on. Yes, yes, yes. We're going to have even more fun today because we have a debate. And unlike the debates on television, you don't have to wait till 9 p.m. on Times Now. It's happening live here and now, and everybody's going to participate. Can I have my presentation? Isn't she pretty? Now, she's not sitting in her home. This is a suite on the A380, the largest airliner in the world. Now, that's some way to travel. And of course, here's another airline offering you whatever you want to eat, whatever you want to drink. Wouldn't it be fun to travel like this? But of course, well, we'll want to have all this luxury. What we're really interested in is on-time performance. We would want to know how many times did that airline have aborted landings or go-arounds? How many times did they develop serious trouble that resulted in the aircraft being called back? Did the aircraft door open in flight or not? And very importantly, crashes. What is their crash history? We love cheese, don't we? Many of us do. Gouda and cheddar and blue. And when we can't get it, and it's hard to get, we still want it. But of course we want it with all precautions taken so that we get to it safely. We want to see the sights of the world from a height. Isn't skydiving really exciting? Really gratifying, really satisfying. But imagine doing that without any protective gear. We want to see the beauty underneath the oceans. We want to see the treasures of the Great Barrier Reef. But imagine doing that without oxygen, without safety. We want to be satisfied. But we also want to be safe. But isn't that asking for a bit much? Having your cake and eating it too? But that is what we want. Some organizations focus a lot on patient safety. Others focus a lot on patient satisfaction. What is more important? And that really is the subject of this debate. And we have 4 exciting debaters. We have Jonathan Gray and Suresh talking about patient safety. Jonathan is the director of Coavita, a wonderful institution that he's built in New Zealand that is not only building, but I have to say has built world-class improvement capacity to drive both local and international change. He's a professor of health innovation at the Victoria University of Wellington, also has a chair at the University of Auckland and the University of Cardiff, and had done his Masters in Public Health from the University of Oxford. His partner today is Dr. Suresh Ramasubban, who has worked in the United States and is a pulmonologist and a critical care expert and has been with Apollo Hospitals, Apollo Gleneagles, Kolkata for the last 12 years. So could we have a round of applause for our patient safety team? So as you notice, we have an Indian and a foreign combo, and just in case you're wondering about is Jonathan supporting the Kiwis in the series, well, he's Welsh, so he's with India. On the patient satisfaction side, we have Dr. Chan Boon, who's got extensive experience from working in the Middle East and in South Asia in both the public and the private sectors. He currently is the group president of Sasteria Private Limited, which owns the Thomson Medical Group based in Singapore and the Tropicana Medical Center Life Sciences based in Kuala Lumpur, Malaysia. And his partner today is Dr. Sanjeev Singh, who in addition to having done an MD and MPhil, also has a PhD in hospital administration. He's currently the medical superintendent of the Amrita Institute of Medical Sciences, Kochi, heads infection control and quality standards. So let's put our hands together for the patient satisfaction team. So what are the rules of the debate? 8 minutes for each debater to put forward their point. At 7 minutes, I'll tell you have 1 minute left so that you can actually sum up. We'll start with patient satisfaction, we'll start with patient safety, move to patient satisfaction, then go back to patient safety, then come back to patient satisfaction. So 8 minutes each, and then you'll have 3 minutes for a rebuttal. And then we're going to have some time for Q&A. In this season of the elections and debates, I cannot but say, let's see who trumps who. So we start with patient safety.
If I could have my slides, please. Honourable friends and honourable opponents, thank you, Professor Sibal. Thank you for the invitation. It's an honour to come here and learn both from you, your wonderful organisation, and all you wonderful people in the audience. Let this be a fair fight. No trying to influence Professor Sibal. But Anupam, can I just remind the audience that your wonderful book is available downstairs. It did extremely well at my conference in Auckland, and I bought 5 copies for my family for Christmas. And you're looking extremely handsome today. But on with the show. Patient safety versus patient satisfaction. It's not a debate. Are we in the business
of making people happy. It looks good, but no. If we were in that sort of world, we would build escalators up to the top of gyms to save people walking. We're missing the point. Patient safety. Now that's what we're about. We're in here to do the hard stuff. We're in here to do the dangerous stuff to save people's lives. And there's a lot of lives to be saved. There is no time for this soft frippery around the edges. We have many, many lives to save. Look at this another way. Has anyone ever heard of a quote that says, "First make them satisfied"? The answer is no. The words you're thinking of that many of us grew up and are tattooed into every one of our skins are, "First do no harm." And talking of harm, first do no harm. I'm going to give you 4 good reasons to vote for the wonderful team that are arguing for patient safety. The first one is, it's not about comfort. It's not about feeling nice. It's about getting the job done. It is not comfy down there, but it is hugely important. Patient satisfaction? It's a distraction. Are great leaders, not ordinary leaders who do, as it says here, that take people where they want to go. You are great leaders who take people where they ought to be. So finally, my last point, when the chips are down, when we have to really look it in the eye and say, what do we want? Then we choose safety more than feeling good. For the men in the room, if you're approached by someone with a long needle needing this particular investigation of your prostate, who do you choose? Do you choose the grumpy, not particularly socially skilled, slightly autistic, but amazingly good surgeon who can give you 100% success? Or do you go with the cheery, happy, funny guy over on the left-hand side who has a 5% error rate? I know exactly who you would choose every single time. And as a New Zealander, we are not happy with our team coming back saying they had a nice time. We want results. We don't want satisfaction. So the opposition are going to argue for pretty, shiny, happy hospitals. But when you look underneath it, studies show that more satisfied patients tend to die more. Doctors reimbursed on satisfaction are seen to unintentionally choose the wrong things for their patients. A focus for what patients say they want means they might get less of what they need. I'm sorry, we can make things look really pretty. So I trained in Scotland. One of the prettiest things you can see is a piper at a wedding doing this. They look fantastic, but I'm sorry, it's a shocking surprise that when you look underneath those beautiful hospitals, you sometimes don't like what you see. Thank you very much.
Thank you, Jonathan. That was phenomenal. A passionate case there made for patient safety, and that patient satisfaction is a distraction, and we shouldn't get distracted. And thank you very much for those visuals. So over now to the patient satisfaction team and over to Dr. Chan.
Good afternoon, everyone. First, allow me to thank the organizers of the conference for inviting me to be a panelist on this debate. It's definitely a challenge. Dr. Sanjeev and I coming to a conference of patient safety, trying to say that you guys should focus on patient satisfaction. But that's the challenge that we have. This is an important issue, and Dr. Sanjeev and I will aim to convince you by the end of this session that not only is patient satisfaction more important, but you should move it closer to the center of your operational strategic map. Now, safety is part of the quality agenda, there's no doubt about it. But just remember, it is only a part of it. So what are the other parts? What are the other dimensions that we are talking about? We like to say that patient satisfaction is an important indication for measuring the quality in healthcare. In patient satisfaction, we'll attempt to show you that it affects clinical outcome, and it definitely affects patient retention. It affects a timely, efficient, and patient-centered delivery of care that we're all looking for. It is a proxy, but it is a very effective indicator to measure the success of your operations. Now let me elaborate. One, SharePoint. Okay. There are several hospital studies that shown that there's a positive correlation between patient satisfaction measures and outcome when we properly control the risk and use of empirical data. Now, I'll just show a few. This is a study published in Circulation 2010. They found that you have higher patient satisfaction is associated with improved clinical adherence and lower inpatient mortality rates. Another article, this was published in the American Journal of Managed Care, this is 2011. There's a higher overall patient satisfaction, and satisfaction with discharge planning are associated with lower 30-day risk-adjusted hospital readmission rates. These are all clinical indicators as well. These findings seem to suggest that the patient-centered information do have an important role in the evaluation and the management of hospital performance. Next, patient satisfaction is a key measure of patient-centered care. There are many possible definitions of patient satisfaction. I took this from Wikipedia. I have a reason for it. I find that this is most apt. The movement from clinician-centered or hospital-centered care has been going for a long time. We have always wanted to move it to what we call the patient-centered model, but a patient-centered model needs a measure from the patient's perspective. And I think taking patient satisfaction is such a perspective. So I think it's apt that we take a look at what the public contributes to the definition of patient satisfaction. 3, patient satisfaction, a higher satisfaction will lead to a lower chance of malpractice suits. In 2005, a study published in the American Journal of Medicine found that that a decrease in patient satisfaction leads to a corresponding higher chance of being sued. Poor communications is often the #1 reason that patients file malpractice suits. Satisfied patients are more likely to forgive perceived care mistakes and are less likely to sue. Improving patient satisfaction is one of the focus or one of the tools that we can use to reducing malpractice costs. But what I've shown you, these are just some of the research and some of the surveys. Most of them are academic, most are otherwise. I pick up a few examples. If you dig into them, you can find many more. But at the same time, you can also find many more studies published in journals that would say that no, there's no correlation between patient satisfaction and clinical outcomes. These measures, satisfaction measures, I think has been used for more than 20 years, but still there are a lot of people who doubt the use of it, who say that no, it should not be done, it's a waste of time, blah, 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 blah. Now, I get this from the doctors and my nurses and all the other team that we have all the time. And I found this recently on the internet that perfectly sums up this sentiment that I always get from some of my staff. They would tell me, is it really important? The only question that matters is, did the patient die? If the patient didn't die, then it doesn't matter. But is it really the case? Now we can argue about it on and off, on and on and on and on. And if you choose to ignore patient satisfaction because you have not seen unrefutable proof, not seen ironclad 100% conclusive proof, then perhaps then I would like to move on and show you some hard truth. This is the hard truth about patient satisfaction, and the most important of it is that we have no choice. Because other than perhaps ourselves and some of you here, every other stakeholder wants it. The patients want it. What do they want? Really? Do they really want super nice environment? Do they really want, you know, as this cartoon say, a nurse in a miniskirt? To move beyond lip service about patient-centered care, as I mentioned before, we need an indicator to measure how well the patient views our effort. And the patients are not frivolous. When we strip down what they truly believe that they want in a healthcare setting that will increase their satisfaction, we will realize that they are not looking for a massage after surgery or meals being prepared by 5-star Michelin chefs. No, I don't think that's what they want. But what do they want? There is a survey that's being used in the US called the HCA-HPS. This is probably the most widely used and studied patient satisfaction survey. And in a study published in the American Journal of Managed Care, this is in 2011, they found that the order of correlation with overall satisfaction based on the categories of experience that is assessed by this survey. And at the top of the list is communication.
1 minute to go.
Communication ranking tops of the list. So not only do patients want better communications with the healthcare professional, they also want the doctors and nurses to listen to them. Truth number 2. The players and the insurers want it. Payers and insurers in every geography that I know are grappling with increased costs. They are putting in measures, a multitude of measures to rein in costs. Some of them would be value-based payments, incentives, and of course they're using patient satisfaction too as well. Because they are payers, and they want to implement such measures, we have to take notice of it. Our bosses want it. For those of us in the private sector, I think this is obvious, but for those of you who are in the public sector, this should also be obvious. Every politician is grappling with healthcare issues nowadays, And none of them would be happy if it's known that a public hospital, their customer satisfaction ratings is always ranked at the bottom. This is not something that's tenable. And lastly, and perhaps more important, your bottom line depends on it. Patients will walk. Poor satisfaction ratings would lead to patients deserting your organization, and there will be financial implications. No patients, no revenue, no job. And in addition, payers now in many jurisdictions are imposing penalties on poor ratings. This is happening in the US and in some of the other jurisdictions that I'm familiar with. And they will use whatever tools they have to incorporate patient satisfactions into their payment system. The system is not perfect, but it will not go away. So therefore, but before I end, there's always a positive side to emphasize on patient satisfaction. The demand for healthcare services will surely grow, we all know that. And if patient encounters with providers will become more multi-episodic over their lifetime. Healthcare organizations, like all of us, should take into account the lifetime value of a patient and not just based on a simple episodic. And more importantly, in the current age, every patient, because of social media, has a social network that will amplify and multiply their satisfaction or dissatisfaction of the service that they received. After all, we all know a satisfied patient will recommend the provider to their entire network. So in summary, if you still find the evidence inconclusive, I would say let the academics sort it out. There will be more studies coming out, but we at the front line of healthcare, we got to take charge of this and we got to move ahead. Make patient satisfaction the core of your operational strategy.
Thank you, Dr. Chan. So interestingly, Dr. Chan, rather than use an emotive pitch, has used a data-driven pitch to appeal to the sensibilities of all the doctors who believe that data is so important. Thank you very much, Dr. Chan. We move on to Dr. Suresh, and he's going to be taking us back to why patient safety is more important. Suresh.
Thanks. Can I have my slides? Good afternoon, everybody. Thank you, Chairperson, Professor Sibyl, for having me over here. How many from Chennai? So we are in a Pattimandram, isn't it? So you are in the land of Pattimandram. So we should be debating in a Pattimandram style. So that's what I'm going to do. So that's for the uninitiated, that's Debate in Tamil. It's a very popular TV show. If anybody hasn't watched Sun TV and hasn't watched the Pattimandram, please go back Sunday morning and watch Pattimandram. You'll get inspired. So that's one of the things that I really want to do. And I'm going to take evidence also as my side. Next slide. Yeah. So when you're trapped between patient safety and this patient safety, you obviously have got to choose a very slow response here. Patient safety first, and I'm going to prove that. All right. So that's my point in the next 7 minutes is to define safety and satisfaction, then tell you how these people have manipulated the system to come to this conceptual flaw of satisfaction. All right, I'm going to show you the scientific evidence favoring safety. All right, we all know this. Professor Sibyl showed me the same thing. I showed the better one. I showed the bedroom in the aircraft. All right, he was very dignity personified. And we know the ECMOs, and we are proud to do ECMOs in all Apollo hospitals, and we know we all do these stuff. So HFOV is an ECMO. So what's next? We have begun, and I'm going to take you quickly through the quality journey which you have been going through, and then come to the confusion created by these people. So we've gone to this, what's the matter with you, to what matters to you, and then what we really need to identify is the fact that when we have gone through this, we find that there is almost a significant amount of death, and we say the to err is death, and then this paper came out saying we have to cross the quality gap, and we are really doing a good job of it. But what are we doing? So the 6 goals that they were set up in the seminal paper was safe, effective, patient-centered, timely, efficient, and equitable. Did anybody see satisfaction in this list? So what have they done? They have manipulated the patient-centered word. That's what they have done. It is manipulation, nothing else. So safe is what we want, do no harm, that's fine. Safety is basically another way of saying, diplomatically saying, don't do any error. And that's exactly what we want to do. We don't want to do any harm to anybody. We want either an error of omission or an error of commission. We want, and eventually safety boils down to the same thing, is looking at the Amitabh Bachchan coin of Sholay. It's the same thing. If you haven't watched Sholay, please go out of this hall. So that's my message. But yes, so quality and safety are the same sides of the same coin. It is not. So you cannot put any other role here. What is safety? You don't want you want an environment. So obviously the environment should not be soap on the corridor. That's safety, isn't it? So you want freedom from accidental injuries. So what we want is patient-centered, and how it has been manipulated to patient safety. The patient care is equal to patient satisfaction. Isn't this? That's what they want to prove. And they're going to use this metric called patient satisfaction. And it's a measure of extent which a patient is content, how he feels, as if he's doing yoga, and this is what they from their healthcare provided. And this all started off with the HCA HPS survey, and it seems that the buzzword now is patient satisfaction. That's why we are here, isn't it? So what is composed of 32 items. This we'll talk about quickly, but as you said, 7 things are nurse communication, physician communication, so on and so forth. But hospital staff responsiveness, and they're going to answer you as always, usually, sometimes, and never. How many nurses that if somebody asks for a hot water in 2 minutes time and you don't turn up because you have a code blue happening in the next bed, and you will have a, oh, never, usually, and that makes you fail. So when these people in the management committee look at this result, they'll say our nursing is poor. No, the nursing is not poor. The nursing was actually looking at a patient who demanded a code blue situation, not a hot cup of tea. So they have cleanliness, sure. What's that? So I have the nurses on my side. So, and this is the problem. All right, patient-centered care is not, it's in the mind of the healthcare leader, it's not equal to patient safety. I use the same picture, but I'm going to use the Tamil word, kindala. That means sarcasm. Are you talking a measure of quality? What is wrong with you? Let's go to basic neurocognitive science. What is satisfaction? Cognitive and emotional. It's a beautiful statement. People will forget what you said. People will forget what you did. But people will never forget how you made them feel. All right, that's satisfaction. But no, we are measuring how fast the nurse gave a hot cup of water. All right, that's exactly what. So emotional events are processed in the amygdala, and you get these things. And if anybody has watched this movie, please go back and watch this movie today. If you never have to understand in Walt Disney fashion what is cognitive, understanding how memories are formed, this is a beautiful movie called Inside Up, and this is a Disney movie, and you will understand how memory is stored. So that's something which you can do. All right. So satisfaction versus safety. I'm going to talk about improvement in patient satisfaction has not linked to quality improvement. I'll show you evidence. No data. So patient satisfaction does not equal patient safety. In fact, it's inversely related. All right, it's not directly related, it's inversely related. What am I going to show you? There are so many studies. I'm not going to go through the measure of healthcare quality, patient satisfaction. And universally, you will see that there is a negative connotation to measuring patient quality and patient safety in majority of these studies. And the data is very, very clear that there is no way you can correlate patient engagement into patient satisfaction numbers, and we should not be using this. And you can see that the cost, what we are talking about, reducing profit and loss. If you concentrate on cost, your drug cost, everything is high. If you concentrate on your scores of surgery, length of stay, which is what is the more important thing in profit and loss, isn't it? Your length of stay is going to be shorter if you don't concentrate on satisfaction. So these are the things which are very obvious as we come through this thing. Criticism of patient satisfaction, that they don't know whether it's an outcome measure or is it a process measure. And we've talked about this, and they really don't know what it is. Is it a measure from productivity, efficiency? They have absolutely no idea, and they have confused this patient engagement and have created this conundrum where we are debating this and wasting our time. I'm going to end by saying this famous statement from Dr. Thomas Paine: until we are able to shift the focus from patient satisfaction to patient safety, you will be just like the healthcare workers will be like rearranging deck chairs on the Titanic while waiting for it to sink.
Thank you very much, Suresh. Very interesting strategy. He appealed to you making sure that he touches on a Tamil television program. He tried very carefully to win votes from the nurses because he knows that there are quite a few. He touched on movies and emotion and television, very interesting. And then of course changed the whole narrative of the debate by turning the data, by saying that he actually questions the way the data has been collected. And I know one person who can actually benefit. So I think after this you should send Donald Trump a mail saying if what he believes will happen and he believes the election is rigged, you could actually tell him how to analyze the data so that he can actually make a passionate case should that happen. Thank you very much, Suresh. We now move on, and Sanjeev, you have a very interesting task. So you have to show that the data that you have used is accurate, and then also approach and try and win the goodwill of this house. So over to you, Sanjeev.
Thank you, Professor Sibal and my colleagues. I think this is a problem for India. Every time we would like to rationalize based on religion and rationalize based on region. And that's, I think, a bad point. I have been in Kerala for 14 years. I have not learned Malayalam, but I am doing well up till now. So I have not regionalized the activity. I'll start on a lighter note. There was a husband and wife. The husband was not doing well. The wife took him to see a doctor. The doctor said, you do a couple of things and your husband will be okay. For next 1 year, don't give him dirty looks and he'll be okay. For next 1 year, don't ask him for jewelry or diamonds and he'll be okay. For next 1 year, don't discuss your mother-in-law and he'll be okay. For next 1 year, don't discuss daughter-in-law, sister-in-law, mother-in-law serials with him every day and he'll be okay. And when they were going back home, husband asked, what did the doctor say? The wife said, you're not going to survive for long. And that's the point which I would like to make. Until unless you are satisfied at home and you are satisfied at a workplace and you get a satisfied customer, it's not going to work. And I'm like to pitch that. Does that work? Yeah, no problem. I'll be faster. This is an advertisement of Mercedes-Benz. This boy always gets out of his house, goes to a police station and asks him that he's a missing boy and he needs to be dropped. That is best or nothing. That's an experience and you need to have that experience. Next one. You talk about precision like German. You talk about punctuality like Germany. But you talk about culture and attitude like Indian, and that's Lufthansa. That's what I'm saying. It is that my wife would really second me on this because of that Pepsi ad. It was just Pepsi and he drank it because of the experience. And those Pepsi lovers knows the difference between thumbs up, Coca-Cola, and that's the experience which I am trying to pitch. Cleveland Clinic learned it well in advance, and this James Merlino, he had his father admitted in Cleveland Clinic, one of the prestigious, and his father expired, and he was very courageous to say that nurse didn't come, there was safety measures, he had Pseudomonas, he has MRSA, he had amputation, he was not taken care, and his father died. And that is where he kept on saying, then patients are not objects. And that's what I want to pitch, Jonathan. It's what you have made as a very emotive statement. They are not numbers and they are not disease. They need to be respected. There is a dignity which needs to come. And that's how Mayo Clinic always put. Now, every hospital uses this, patients come first. But they come first if you communicate with them well and you engage them. I think we are, what we do in medicine the best, and that is what my colleagues on the other side are doing, is presenting lots of data and twisting it
and they're saying that we are twisting. Basically, it's a twisted mindset in medicine. Because you say the beta blockers you give for coronary artery disease that it's going to help. There is a similar study which says giving beta blockers are creating mortality. So you actually never know. First have a satisfied customer to get in, and then we'll talk about patient safety. Our team said that we are twisting patient satisfaction into centerness. If there is no patient centricity, and how is the patients who are going to come to the hospital be satisfied? They need to be happy. And the focus of the providers needs to be on the patients, and that's what the Institute of Medicine came up with this they need to be respectful and responsible. We have in that era of becoming a doctor and becoming very, very curative because we want to treat everybody, we have lost sensitivity to the patient and the dignity with which he comes in. And that's the bad point. Dissatisfied patient, Jonathan and Dr. Suresh, is the next smoking. And Peter Drucker, the management guru, said, if one dissatisfied patient goes out of the hospital, he speaks to 41 of them, they are not going to come. What patient safety measures we are talking about? Our team said about ECMO. If 41 patients don't come, what are we talking about ECMO? One satisfied patient talks to 9. You have to get satisfied patients into your hospital, and then only we can have a running hospital, first of all. Then we can talk about patient safety. Customer satisfaction versus have we lost our way? And we have, because there is so much of energy and concept we are putting into this. In NABH, from the research committee, we have 11 mandatory indicators where we collect data. You will be surprised to know what is medication error data from 413 accredited hospitals. Can you imagine? International Safe Medical Practice has 8.2%. India, from accredited hospital, has 0.09%. And they are talking about patient safety. There is no data, there is no collection, and there is no culture. So New York Times came up with this, that there are sick and scared who are coming to the hospital. And they expect timely results, and that is going to be the satisfaction point. There are various hospitals who do a lot of good work to say that they need satisfied customers. Like a Maggie hospital, they have this caricature which is there outside, and they can write in all their points. What are they comfortable with? What are they going to facing with? What are their likes and dislikes? And that is being provided. And you need to go to that extent. How do we go to that extent? Is ethics. We are talking about patient safety, where doctors go on rounds, they don't even discuss with the patient. There is no autonomy. He doesn't participate in the decision making of his disease. Doctor goes, they decide, and they go back and see the next patient. There is no ethics. Why to talk about patient safety? Where is the beneficence? We keep talking about harm, and that's back to basics, but there is justice which needs to be delivered, and that will be delivered once you are sensitive to his requirements.
1 minute, Sanjeev.
So there is an educated customer in India. The internet, the social media, the culture is changing. He's a very informed customer, and we have seen this. We talked about, and my close friend, he took the nurses applaud, but nurses play a basic role to get the satisfied customer, and we need to know whether he's rating us or he's going to come back to the hospital. If he's going to come back, then only we can provide some kind of a safety to the hospital. Unfortunately, patients come with a lot of psychosomatic illness, and that's the Michigan study. 40% of, if you're not going to talk to him, if you're not going to communicate properly, he is not going to be treated well. Safety comes after that. All accreditation programs, I'm not sure what data my colleague captured, but this is a systematic review, and it shows patient safety has an impact, and there are close to 11 elements which shows that it does pay. And 5.7 core indicator of ISQA is that quality dashboard. We are developing, getting so much of data, but what is important is to get a happy customer, and we measure, every hospital measure that, and that's going to be very, very important. I'll leave with this point. Well, Donald Berwick said we have two jobs, our job and job of improving our job, which we can do only by a satisfied customer who is going to keep visiting us and be healthy. Thank you very much.
Thank you. Thank you very much, Sanjeev. The learned audience must note that Sanjeev started by talking about not playing the regional card and did not talk about the Tamil card, but very cleverly realizing that most of the nurses are from Kerala, said that he's been working in Kerala for 14 years. So please let that be noted. Clearly, our debaters have been following the three debates very, very closely because you can see the similarities. We have terms like manipulation. We have terms like being sued. We have terms like playing with the mind and, very importantly, twisting facts. So we now move on to the second round, and we're going to have Jonathan for 3 minutes.
Thank you very much. Great to be back up here, and let's take on a couple of those simple facts that we've just heard and help the opposition to understand how they've been misled over the years. Let me take you back to where I trained in the UK a long time ago. There was a GP there who, according to all of the studies, all of the surveys, and all of the qualitative interviews, was described as being the perfect, capable, caring GP. He was loved by his patients and he gave them everything they seemed to ask for. That GP was called Harold Shipman, and he killed 215 of his patients over a 25-year period. And he had very satisfied patients. Let me take you back to patient-centered care, and I'd like to take up the point that was made. The Institute of Medicine talks, and it actually said on the slide, so that was very helpful for our cause, the Institute of Medicine states that patient-centered care is respectful of what the patient needs, not what the patient wants. So I was working in critical care, and I had a nurse who came to me because a patient was arguing with her. This patient believed he was being mistreated. I went along to have a chat, see what I could do, and the reason he was feeling he was mistreated was because he didn't get enough pastrami on his sandwich that lunchtime. He had recently had a quadruple bypass and it was totally inappropriate he had it, but he complained. So I just want to put up a couple of points about satisfaction. I think they fail to make the argument that it's more important than safety. We do not want our hospitals full of very happy people who are dying early. And if you don't believe that, I'd just like to throw in one more piece of evidence, and you can look him up. Professor Joshua Fenton at the University of California has published a study that showed doctors who were reimbursed according to satisfaction scores might unintentionally fail to look after the best interests of their patients, focusing on what patients want, and they then get less of what they need. I put to you in summary that our opponents, lovely people that they are, have actually proven our case. The danger for all of us is that we might see a future, if they win, with fantastic patient scores, yet higher number of dead patients in our hospital. Thank you very much.
Thank you. Thank you very much, Jonathan. And let the audience please note, he has done what one of the presidential candidates is doing in the United States, worry about the opponent wins. Over to Dr. Chan. 3 minutes.
Thank you. I think what our opponents here have done is to perfectly dichotomize the issue. That if you're not for patient safety, you're definitely against it. And I think that's the wrong approach. And then we have, Dr. Sanjeev and I have always said, that's the wrong approach. We did say that yes, safety is part of the quality culture, but we are saying patient satisfaction is also an important. Our point is just that we think that we should make it more important. Patient-centered care. Why we say that satisfaction is so important a part of what we want to do in patient-centered care, and I repeat this because this is the one measure that is from the patient's perspective. How can we say that we want to do patient-centered care without taking into account what is the patient's perspective? It is not true that patient satisfaction is everything about what the patient wants. That I don't think is true. In fact, what we're trying to show
is that patients' wants and needs are not as frivolous as what we think. I mean, we always talk about the story that, you know, you get a big complaint from this patient who wants the hot water within like that, or they want the food served warm and cold at the same time. And I think when we strip down some of what truly reflects patient satisfaction, which is what we brought up that study that's published in 2011, is that patients value some things that more communication with nurses, communication with doctors. This is what they value more, and this is what will drive their satisfaction higher. And why is the patient's perspective in this important? Because they are not totally oblivious to what is happening around them. I think patients are sensitive to the communication, not just to them, but they also sensitive to the communication that seems to be happening or not happening amongst the care team. When the discharge process is poor, when the scheduling for important clinical tests got messed up, it is an indication of how well the care members on the same team are communicating with each other. And that makes it important, and it affects the satisfaction quite a bit. Do I have more time?
You have 10 seconds.
Oh. Then I'm satisfied.
Beautiful closure. Passionate case for patient perception, patient centricity. Thank you so much, Dr. Chan. Over to Suresh. 3 minutes. Yeah, after you get there, 3 minutes. Could you have the slide, please, on for
I'm a Tamilian, born and
Suresh?
brought up in Delhi, studied in Pune, and now living in Kolkata, and have gone out of the country also. So no regionalism, no chauvinism. I can speak as well in Bengali as in Marathi. So there is no regionalism,
Slide,
so
please.
no under the belt before I start. All right, slides, please.
Yeah.
Rebuttal. I didn't have a picture of a butt to say rebuttal, but still.
Yeah, this is not counted, yeah.
Right, I'm just going to again and again say the issue that we are forgetting is satisfaction. We are not denying that satisfaction is not important. What is it? Is to measure satisfaction is wrong. Is to measure satisfaction by surveys, by giving numbers and giving a particular value to it is wrong. And that's exactly what I want to say. As we pointed out, Michael Jackson, a very satisfied customer. But does it avoid a lawsuit? Does it avoid a lawsuit? Does the caregiver of Michael Jackson, has he avoided a lawsuit? And the answer is no. So just satisfying a patient is not adequate. What we are asking is, should you measure satisfaction? And should you link payments to satisfaction in the hospital? What should you link payments to? You should link payments to the quality of care. That means no error in the process of caregiving, not on the question of how satisfied were you, how fast the nurses got into you. Yes, and the term that they are manipulating and not understanding is not patient-centered care, not patient satisfaction. The term is empathy. If anybody wants to take home a message, go back, is the fact that we need to be empathetic to our patients rather than to satisfy them. Empathy means to know what they feel, to see what they feel, to hear what they feel, and that will answer all their questions of communication, of doctors, communication of nurses, and everything. And can we measure empathy? Can you go and ask my wife, is my husband empathetic? While reading the morning newspaper? No. In the afternoon? Yes. So empathy cannot be measured, and to equate empathy to patient-centered care and to equate patient-centered care as patient satisfaction is completely wrong. That's what I have to say.
You want to show any of these slides?
So this is what I wanted to say is you have so many things in patient-centered care and satisfaction doesn't come through that. And the picture that I wanted to show you was this, that it's not this thing. It's time to administer the patient satisfaction survey. So what does medical care actually require is this. So I think the buck has to stop here. We should stop measuring satisfaction in any form. And we need to communicate, we need to understand, we need to see their world and appreciate them as human beings, and this should not be equated to satisfaction. That's all I rest my case.
Thank you very much. Over to Sanjeev for your 3 minutes, Sanjeev.
Dr. Suresh made my work very, very easy. I'm very sorry for him. He says his wife is not empathetic. So, other than the bias that it's a patient safety congress, there was this wife who came into her house, and she went into the bedroom and she saw 4 naked legs, and she got very wild. She went into the closet, got the baseball bat out, started hitting so badly until there was no noise. She went into the kitchen and she was surprised to see her husband having a drink. And her husband said, "Hi honey, your parents had come over." And other than that bias, there is nothing which our opponents in Patient Safety Congress are actually presenting. Dr. Suresh, Dr. Suresh also said numbers is wrong. Patient safety measurement is all about numbers. In fact, patient satisfaction has a humane aspect, and there is elements to it. He said that quality is related to patient satisfaction. If you take a vote, if I take a vote, what is quality today? Quality is all about paisa vasool. Is your paisa vasool when you saw pink, when you spent 150 rupees, and that's what it is. In fact, patient satisfaction has gone beyond. It is also a satisfied customer is now being seen at end of life care. Is he satisfied when he's dying? That is the magnitude where the satisfaction has gone. Unfortunately, they have just put that and connected to code blue and hot tea being provided. Is that healthcare? I don't think so. Code blue happens once in a day. Hot tea you need to provide every call bell, and that's important. So it's back to basics. The basic is we all have been taught do not harm. That is there in the curriculum. Unfortunately, patient-centeredness, education, engagement, involvement, communication is not within our curriculum. It is within our culture. Trust is within our Indian culture. We trust. We don't find out whether you have done CABGs and your infection rates. We trust that doctor and we come. And I rest my case.
Thank you very much, Sanjeev. So we've got time now for 2 questions each from the audience. I'm going to start at the back and then work my way forward. 1 question first for the patient safety team. Anyone has a question for the patient safety team? There we go.
Sir, if I'm a patient, I would definitely like to vote for patient satisfaction. The reason being, patient safety is the culture. If I'm traveling in a train, I will not be thinking whether there will be an accident of a train or not. But I will definitely see how my journey is there, how my experience is there. So if I'm in healthcare also, definitely I want to see what is my patient experience, not safety, because safety is part of it.
Does the safety team want to counteract that? Counter that? Could you have the microphone on there, please?
Yeah, patient experience does not equate patient satisfaction, and patient experience is not equal to patient satisfaction and cannot be measured in the numbers is what they want us to measure, and to penalize us for not being patient satisfying you. And that's exactly the point. The point of the debate is we understand that these are the 6 things that are important. It is patient-centered care or an empathetic care. Don't measure it. That's all my request is.
Okay, this one is for the patient satisfaction team.
I go to a hospital, get a LASIK done, and subsequently I'm not going to see the vision. So where are I going to stand?
He's saying that I happened to get a LASIK done, vision tested, and he's lost his vision. So where is he standing?
Then I think you are definitely not a very happy patient. because this moved beyond satisfaction or safety. This is not a safety issue, it's also not a satisfaction issue. It's a clinical issue.
Right, thanks. This one is for patient safety.
So we have had a very interesting debate where the patient safety team says that satisfaction is not required, and the satisfaction team saying first satisfy patients, then bring patient safety. My question is to the patient safety team. If I ensure patient safety, would you want them to be satisfied?
Microphone, please. We can't hear you, Suresh.
If you provide safe care, satisfaction automatically follows. That is what I would like to say.
And the last question for the patient satisfaction team.
I will certainly vote for satisfaction.
We are not voting.
Only a question.
We will take a vote too, yeah.
Yeah. Satisfaction includes safety. It is part and parcel of satisfaction. Whereas safety does not mean that satisfaction is there. Therefore, satisfaction is a broader concept, and that's what we need. Therefore, I will ask the team, satisfaction is better, a broader concept, and that's what we need. We know that all four of you are real good friends, and Anubhav is with you at the end of the debate. So you need to look at them and say, sir.
Thank you. And now it's time for the voting. So all those, no, we had two questions, sorry, because we will do this later because we are running out of time. So all those who believe patient safety is more important, please raise your hands. Patient safety is more important? Okay. And all those who believe patient satisfaction is more important, raise their hands. Wow. We'll have to do this again. So all those who believe, no, only one hand, you can't have two hands and stand up also. So patient satisfaction. Patient satisfaction, who all believe in patient satisfaction? And who all believe in patient safety? And who all believe in both? So both teams win. Thank you so much for a spectacular session.
Would like to thank the participants for the intense, healthy and lively debate. And of course, our dynamic chairperson, Dr. Anupam, for playing the role of modern-day Narada to perfection. He set the two teams against each other and he got the best possible outcome. Over to Dr. Matangi.
Thank you, Dr. Venkat. May I request Dr. Mamta Soni, Senior Consultant Hematologist at Apollo Hospitals, to come up on stage to award the mementos to Professor Jonathan Gray and Dr. Chan. Dr. Chan. Dr. Chan. Dr. Chan. Yeah. Dr. Mom. Request Dr. Venkat Subramaniam, Senior Consultant Surgeon, Apollo Hospitals, to give away the mementos to Dr. Suresh Ramsuban, Dr. Sanjeev Singh. Can I call upon Dr. Meenakshi Sundaram, Consultant Gynecologist, to come up on stage? Dr. Meenakshi Sundaram? To Anupam Sibal.
We'll now adjourn for lunch and assemble at 2 o'clock for the breakout sessions.
அந்த ஆப் ஆஃப் பண்ணிட்டு